I'm Mabel Jong, and welcome back to our continuing coverage of World Healthcare Congress 2017. We're glad to have you. We also have Shawn Bloom here in our studio, President of National PACE Association. So glad to have you here, Shawn.
It's a pleasure to be here. Thank you for inviting me.
Well, tell me, what is PACE exactly, and how is it different from other healthcare organizations?
Yeah, PACE is somewhat still a relatively new model of care. We were created under Medicare as a permanent provider benefit in 1997. And PACE programs are unique in that they bring together all Medicare and Medicaid services into one provider organization. So we are probably the most fully integrated model of care for frail seniors. And by virtue of how the integration of care takes place and the full financial risk that we bear under Medicare and Medicaid, we are often referred to as the original accountable care organization.
Oh, interesting.
And the alignment of all the incentives when we're fully at financial risk and provide all needed care really allow us to remain really focused on helping the elderly stay in their homes, out of the hospital, out of the nursing homes.
Okay.
When they win, so to speak, and be able to live in the community, we win, and we can reinvest those scarce dollars back into primary care and community-based services.
And how do your members find you, and how do they qualify for care under PACE?
Yeah, to be eligible for PACE, you have to be 55 years of age or older. You have to live within the PACE service area, which is generally about a 45-minute driving radius around a day center. And you have to be deemed or defined as nursing home eligible by the state in which you live.
Okay.
They find PACE through a variety of different referral sources. Typically those are the state long-term care determination process. It could be other providers, it could be physicians, could be hospitals. And typically individuals in need of long-term care enter the long-term care system immediately following some healthcare event.
Okay. Do you keep track of data that really shows that this model of care is sustainable and maybe scalable?
Yeah. We represent all PACE programs throughout the country at the National PACE Association. We collect comprehensive medical, pharmaceutical, and demographic data. Our folks on average use less than 3 hospital days a year. That's about on par with the average Medicare beneficiary, yet our folks are probably the 10% of the frailest of them. So we're really able to quantifiably create value. 100% of people that are enrolled in PACE are nursing home eligible, but yet on any given day, and this goes back for 10, 15, 20 years, only 7% of people actually reside in a nursing home permanently. So we have a success rate, so to speak, of 93%. And then under federal law, states are required to pay PACE less than they would have otherwise paid under fee-for-service, traditional Medicaid. And the average savings that states calculate is about 10 to 15%.
Wow.
And then
Okay.
federal studies by the government have indicated at worst case scenario, we're budget neutral to Medicare, but more than likely save money. So we save money, we provide unparalleled outcomes, and the degree of satisfaction is extremely high.
What do you say are really the key components behind the success of your model?
Again, it goes back to the core component parts. We are typically sponsored by community-based organizations. We are at full financial risk. There are no exceptions, no copays, no deductibles, no benefit limits, and we are responsible for all needed health care. Healthcare organizations that are at full financial risk that are responsible for everything look at the delivery of care very, very differently than those that are only responsible for a piece and bill for each one of those pieces.
Do you think that your model of care can be transferred to other segments of healthcare? You focus on the frailest elderly.
Yes, good
but
question.
Can we look at this as addressing another community of patients?
Yeah, last September, the previous president, President Obama, signed the PACE Innovation Act, which authorizes HHS to initiate a pilot that would allow PACE programs to serve individuals that have a nursing home level of care need under the age of 55. And CMS has issued a request for information. Those comments were due about a month ago.
Okay.
And we anticipate in 2017 that CMS, the federal government, would launch a new initiative to explore the applicability and benefits of PACE to younger disabled individuals.
Okay, and
among other populations.
is there a high degree of projected success with that kind of program?
It's a pilot, but I think we've worked very closely with the disability community, national and state chapters. I think they're really seeking individuals with high needs really need a close proximity to the provider, not necessarily the health plan or payer. And I think the disability community has been very supportive of us exploring some of the benefits.
Okay. Okay, great. And what is another key takeaway you want to leave with attendees from this meeting?
Yeah, well, it goes without saying the world of healthcare is changing dramatically. If there are 2 or 3 driving elements of change that are taking place, it's really coordination. It's the aggregation of services into bundles and a very strong focus on value and accountability. And that's quite honestly, those are 4 characteristics that you cannot argue exist in our current fee-for-service fragmented delivery system.
Okay. May I ask how you're finding the meeting so far? What brought you to the World Healthcare Congress?
Yeah, it's a meeting that takes place here every year. I'm looking forward to going to sessions, and it's always good to catch up with colleagues and make a contribution to individuals learning that are present at the conference.
Great. Shawn, thank you so much for your time.
Thank you very much.
And I'm Mabel Jong. Thank you for watching. Stay tuned, much more to come.